It's my pleasure to introduce Susan Stefan. She will talk a little bit more about her background, but Susan and I have been working together for such a long time. And she is one of the people I absolutely adore in this field of suicide prevention. Her perspective, her sensitivity, her breadth of knowledge all really contribute to such an amazing perspective on how we can do a better job with keeping the person, keeping the individual in the center of our focus and of our care, and at the same time understanding the legal and risk ramifications of working with people with suicide prevention, how to balance those two. I absolutely love the title slide, how to actually help your suicidal patients without having nightmares about liability. Dream the impossible dream. So, Susan?
Thank you. It is such an honor to be here and an honor to work with Ed, who is a national superstar, and people in Massachusetts who are more local may be unaware of how much of a national superstar Ed is, and what a great guy. And it's a rare combination. It's a rare overlap. So thank you. And thank you also, Laura, because I would like to begin this also by saying I have close friends who have died by suicide. I have clients who have died by suicide. I have former clients who have died by suicide. And I also have a large number of clients and former clients who are chronically suicidal, who there was one person who would call me every week for 7.5 years, every single week saying, this is it. I'm going to do it. I've got a plan. I've got a time. So there, besides suicide, there is a huge, it's kind of like the Titanic, and the people who are dying are the tip, and underneath are just millions and millions of miserable and desolate people who are looking for a reason to live. And I want to remember those people too. This is going to necessarily be an overview because Ed asked me to talk about 3 subjects, each of which I have spent 1 hour in presenting to people on. And he said, can you do it in half an hour so that you can have a lot of time for questions? So I'm going to do my very best. These are the 3 subjects. So in writing a book, I believe that when you write a book about people, you really, really need to talk to as many people as you can who you're writing about, so you have some clue what you're saying. And I ended up spending almost 1,000 hours talking to people who had made serious suicide attempts and surveying people, and not just people who had made suicide attempts, but also mental health providers, nurses, social workers, psychiatrists, psychologists, EMTs, counselors, so to get kind of a picture of what was going on. And I am going to be talking about what they said they need, even though it's intensely individual. Each person's story is intensely individual. There were a number of common themes that emerged. I'm going to talk about a few of those. When I talk to providers, the barriers to meeting those needs, fear of liability came up over and over again, lack of time, lack of training. I'm going to talk a little bit about that. And finally, so that this isn't a complete downer, there really are solutions out there. And one of the things I like about CAPES is the title is about accelerating practices, not discovering them. We know what works. We have a system that thwarts and obstructs doing what works, not only to prevent suicide, but to help people be a little less miserable. Now, talking to people, an overwhelming theme. When I first started talking to people who were suicidal, I would do this little thing because, like, I'm a lawyer, and I'd say, look, if you're getting really upset or triggered, we can get off the phone anytime, and you just tell me if this is too upsetting. And ordinarily, it would be me saying, after about 2 hours, I gotta go. Like, I gotta go. People wanted desperately to talk, because they knew they could talk to me and I didn't have the power to involuntarily commit them. And the fear, the terror of being involuntarily hospitalized and the desperate need to talk is one of the things that emerged the most from these interviews. And the other thing that people really hated, and I understand why you guys have to do this, and I will get to this. I understand why you guys have to do this. They hated the standardized, most of these people had gone to EDs many more than one time, and they hear the same questions. And it's just like here is someone thinking, do I want to live? And they're being asked a bunch of standardized questions. Nobody wants to actually hear their individual story. Nobody even wants to help. They just want to assess risk. They just want to triage and like flip you on to the next place. And the idea of being in so much pain, you were trying to decide whether to live and being given a standardized risk assessment form, people really didn't like that. So this is one of my favorite slides. It's not absolutely, does not apply to every suicidal person, but I think as an entry point to talk to people about suicide, two of my favorite questions are, what needs to change? Because if you ask what needs to change, you're kind of changing the framework right away from what needs to change for you to want to live. And that is Will Hall, who said this, had no idea about CAMs, had no idea about the concept of suicidal drivers. But what needs to change is very much a CAMs kind of related question. And also another question I was taught by Dr. John Berlin, who is another superstar, was why now? Because if you do actually have the time to ask people who have just made an attempt or who are in the ED, they will generally tell you the reason that I want to kill myself is something that has been the case in their lives for some amount of time. So why now? And I think that's a good question that teases out acute suicidal risk from chronic suicidal risk, like the acute trigger or driver from the chronic situation. So people say what I really need is to talk, to have time to talk at length about my feelings, about whether I want to live or die. And this is what we have as a system. Hotlines, I don't know how many of you know this about hotlines, but they have limited amounts of time. They got like 10 minutes. So you call and you're saying you're settling in for your discursive narrative about everything about your life, and they're going to get you off the phone in 10 to 15 minutes. And if they think that they haven't really stabilized you, they'll call 911. So the person will end up in the emergency department where honestly, there's bodies stacked like cordwood in the halls, and EDs are very clear that they're not the place where you're supposed to be able to talk for a long time about how you're feeling. Plus, 70% of people, this is another research study, not mine, don't want to tell the truth because they don't want to be involuntarily hospitalized. So what the EDs will say is, we're going to send you on to an inpatient bed and they're going to give you treatment. And the inpatient beds are like, oh no, not us. We're just here to stabilize. We have a short term, and this is really something you need to work with in the community. And so we're just here to give you stabilization. So you can't talk to us either. And then you go to the great community, the great idyllic epic place where you're supposed to be able to talk about suicide. I got this from a forum. I mean, one of the great things about me as a lawyer, and you guys should know, I lurk around professional forums because the stuff people say on forums, it's just like emails. Emails are discoverable, by the way, guys. And forum posts, like when you can get on them, I can publish this in my book. And this is what this person said on a forum. Like, you can screen these people out. You don't have to accept them. And this is what the people I interviewed said over and over and over again. Oh, sure, I had a therapist. And the minute I actually started talking about suicidality, they were like, oh, you're too complex for me. Or they called 911. So ultimately, there is no place to do what people say they need to do, which is talk about how they're feeling. Now, I don't want you to get like, when I wrote my book, I said, providers and people who are suicidal are joint victims of a society that does not want to give people, they say they care about suicide, they don't. And providers are truly devastated by the deaths of patients. And imagine working hard to help someone in a system where you can be blamed not only in public, but in court, blamed for the death of someone that the system itself never gave you time to help, ever. And I have interviewed ED doctors. I have interviewed people who you would think like, upper income people who just felt powerless and burned out because they wanted to help people and they were caught in a system that would not let them have the time to give the people the help that they needed. So there's also mental health professionals, 30% of mental health professionals said they would not ask people about suicidal feelings, either because they felt like they didn't know how to deal with it, they weren't trained to deal with it, they were worried about liability. But if you bring it up, whether somebody's asked about it or not, as this person who I interviewed said, they go into crisis mode. Let's pack her off to the next level of care. And again, acute care hospitals are no solution to this. They don't want to actually let people talk about suicidal feelings. I interviewed somebody who said, I'm trying to decide whether to live or die, and they're trying to help me make a craft box. Like the group things don't really track. And one thing that was really clear is that people that I interviewed made a huge distinction between talking to therapists, which they really wanted to do, and going to psych hospitals where they said pretty consistently, I don't have anything in common with the other people here. Like the treatments they're doing have nothing to say to me and my problems. Now, liability concerns, I have spent, as Ed knows, I have spent years going around the country, state by state, because liability concerns actually honestly amount to somewhat of a pathology among mental health professionals because they are so exaggerated. They are like so completely unnecessary. And in Massachusetts, of all places, they're pretty exaggerated and unnecessary. So first of all, Massachusetts has one of the lowest suicide rates in the entire country. The last data that I saw published was 453 people in 2021, and less than half of those people were receiving mental health care at the time. So you're down to 204. The people receiving mental health care a lot of them were in substance abuse treatment. They didn't parse that out, but a lot of people, very sadly, who kill themselves or overdose, or we don't know whether it was died by suicide or overdose or some ambiguity there, has to do with substance abuse. So what I did, I have access to jury verdicts. I have access to settlement databases. I have access to case law databases. I also am good friends with people who bring malpractice suits in Massachusetts. In the last 5 years, counting pending suits and suits that have been resolved, in the last 5 years, there have been 8 lawsuits about suicide in the last 5 years in Massachusetts. And a plurality of those that went to trial were won by the defendants. I know you don't want to go to trial, but so there's lawsuits and then there's winning lawsuits. Now, I want to be really clear that the 8 does not include jails and prisons. When I wrote my book about suicide, like I said in the beginning of the book, this is not going to cover jails and prisons because jails and prisons, oh my God, like really, if you want to work on ending suicide, you really need to go to jails and prisons, and especially jails. So this doesn't include jail and prison lawsuits, and it doesn't include a growth industry in Massachusetts, which kind of surprises me, which is lawsuits against universities by students, which I thought the Massachusetts SJC had shut down because they came out in favor of MIT and the case against MIT. But anyway, 8 is not like, compared to the number of providers. By the way, Massachusetts is #1 in the country in mental health providers per capita. So really, as just an absolute number, got nothing to worry about. Second of all, it's a myth. People think, oh my gosh, I discharged somebody, they killed themselves, I'm liable. That's completely not how it works. Liability is not based on the result, it's based on the violation of professional standards as demonstrated by documentation or the lack of documentation. Now, suicide, unfortunately, you'd think there'd be more people because families are devastated and they are desperately looking for scapegoats. But lawyers, who a lot of you don't like, lawyers are your first line of defense because lawyers are not going to take cases that demonstrate a careful exercise of professional judgment and professional standards. I have friends and they turn away dozens of families. They look at the documentation, they say there's no case here. So lawyers screen out what are emotionally devastated families desperately trying to not blame themselves. Now, I have been following, there's so few cases in Massachusetts. I've also looked at all suicide liability cases in Utah, Oregon, Washington, Maryland, Texas. People ask me to come talk and basically deliver this message. And I look at everything because I can, because there's so few cases. There are some new areas that 10 years ago would not have been foci, if that's the word, of liability. Failure to access readily available records and collateral sources, and I really want to emphasize the readily available here. It's not like you're not supposed to dig into where were they, in another state. But if somebody has been in your hospital and you can type it up on Epic and find their records from your hospital, you really should. If mom is saying, I want to talk to you, confidentiality never prevents anybody from listening. So you really should access collateral sources to get the information they have to offer. Now, lack of coordination with aftercare. It actually did used to be the case. EDs discharge people, hospitals discharge people, and that's it. You don't own them anymore. That is not true. The Joint Commission says that's not true. Litigation says that's not true. But all you have to do is exercise common sense in having a decent discharge plan and coordinate with aftercare and family. So the Beverly case involved a guy with autism who, those people are very hard to help. There's very few services. And the hospital held him in the ED, There was an involved mother. And they eventually discharged him, didn't tell mom. So this is what I mean by most malpractice cases involve kind of jaw-dropping negligence. I talk about the jaw drop rule, things you would never in a million years do. Nobody in this room would do, nobody on Zoom would do. Somebody tries to hang themselves in an exposed rafter in a hospital room. They're very badly injured. They get sent off for medical care, sent back to the hospital. They're put back in the same room with the same rafter. That's the level of negligence that I'm talking about. Failure to complete safety plan, that is now starting to pop up as something that is a professional standard. And absolutely, failure to at least attempt to restrict access to lethal means. You can't control people in the community. There's, a long series of Texas cases about how, you can't control access to lethal means. I don't know if Massachusetts would be as sympathetic to gun owners as Texas is, but you can ask, you can counsel, and there is all these acronyms, oh my God. But there is a good, CALM is a good access to lethal means module that you can use. EMTALA, I've done an hour-long presentation on EMTALA. EMTALA, there are people who really think that you need to stabilize, namely provide some treatment in the emergency room. That is controversial. Also, if you're not admitting somebody to your upstairs floor because they're Medicaid, EMTALA really doesn't, the folks in the federal government really don't like insurance discrimination, because that's the whole point of EMTALA. Inpatient is less newsworthy. It's always been about environment of care. That doesn't mean you have to be like the emergency department I visited in Texas, where they put the psych patients in a bare room with a concrete floor with a drain in the middle of it. So yes, you can be attentive to environment of care without further depressing an already suicidal person. Again, the same thing. This discharge, transition points. Me as a lawyer, I look for communication around transition points. And that needs to be done well. I know you're sick and tired of hearing about documentation, but documentation is really important, not just in the behind covering category, not just in the Joint Commission licensing category. Think of it as actually helping your patients. So someone's going to come along who doesn't know this person. You've spent time with them. You've learned something. You have some wisdom that can help them. Document to try and pass along information that's helpful to treat the person. That's important. Now, in terms of, liability, one of the big mistakes is you come to a decision and what you document is just what supports your decision. Don't do that. Document that you thought about the risks. You were aware of the risks, you weighed the risks, and you tried to mitigate the risks. There are known adverse effects of involuntary treatment on trauma survivors, people with diagnoses of borderline personality disorder. People will tell you, if you ask them, that involuntary treatment ends up increasing their risk of suicide because they lose trust, they lose the feeling of control, and they also feel like, boy, if people are this panicked about me, something must be desperately wrong with me. Document all contacts with family, the patient, the provider, including telephone, including email, and document using the patient's words. The more individualized you can make this, my stepdaughter's a social worker and she sent me some of her early documentation. I said, my rule is, how many people could this be about? If it can be about like hundreds of people, then it's not good documentation. It's got to be something that is specific and individual to the person, as close to contemporaneously as possible, and don't document later and backdate. We'll get to that, back time. Definitely document review of medical records and consultations. Consultations always helpful. Avoid cutting and pasting. This is something people love to do. I think Epic does it automatically, but cutting and pasting makes it look like it's just rote, it's just mechanical. And especially, and I probably don't have to tell anybody here, but you tamper with records. First of all, most mental health providers who do this don't know how to do it. It's easy to find, and it's an instant win, and it's punitive damages. And for God's sakes, don't do it. I feel embarrassed even saying this, but I can't tell you how many cases I've been involved with where people did it. And as I said, they did it really badly. Solutions. So I don't like the alphabet soup, but I am such a fan of, and the research supports it, and my interviews support it, is the target, like your treatment, it has to be focused on suicidality. This idea, which I think Ed Schnidman, decades ago, the father of suicidology, said, suicide is not 100%. It's not about mental illness. It's not about depression. There's tons of people who are depressed who will never go on to, kill themselves or even think about suicide focus on the suicidality itself. The great thing about CAMS is it embeds all the things that you need to do in terms of avoiding liability while providing really good treatment for the patient. So you have a risk assessment. You do CAMS, you've already got the risk assessment, you've got the documentation, you've got the safety plan, it's done, and it is evidence-based, and it is recommended by NIMH. So if you're worried about liability, there's nothing better than to say, I did this evidence-based thing, NIMH recommends it, I filled it out completely, and here is all the things that are recommended: safety plan, documentation. SPI is a safety plan that it requires provider involvement, and providers should always review safety plans. So Jasper, which Ed was talking about, Jasper is great, also includes a lot of stuff: risk assessment, education, because a lot of people who I talked to said, nobody tells me what's going to happen. I'm sitting here, I'm anxious, I want to kill myself, and I have no idea. People like plunk me in a room, and I don't know what's going to happen. So Jasper gives some idea of what's going to happen in the immediate future. It's got videos of peer support. It's got risk assessment. It's got a safety plan filled out by the patient, reviewed by the provider. And as I said before, CALM is lethal means counseling. Now, peer support, I have lived through this also. Lived through this is really great. Alternatives to suicide groups have been going on for years, supported by the Department of Public Health. I admit, even though I'm hip and I've been an advocate for people with psychiatric disabilities for 35 years, the first time someone told me, oh yeah, there's a group of suicidal people meeting together to talk about their suicidality, my first reaction was, what? But no, it is helpful because they can talk at length without being worried about being involuntarily committed. People don't rush out from alternatives to suicide groups and try to kill themselves. That's not what happens. And so one really helpful thing in terms of discharge is to give people access to alternative sources, because maybe those therapists in the community are going to say you're too complex. But their peers are never going to say you're too complex because they've been through it and they know. And warm lines, hotlines will cut you off, warm lines won't. Warm lines are also peer staffed and they let you talk for 2 hours if you want. Now, this is another person I really respect a lot. He's a guy called Dr. Joel Dvoskin. And one of the things that I think is the worst thing about how we treat suicide is that we are so crisis-oriented. And what I've learned through my clients and the people I talk to is this is a long-term thing for a lot of people. I know that there's a theory about impulsive suicides, and I'm not discounting it. I think the action may be impulsive, but it follows a long journey of having given this some thought. And we don't attend to the long journey. We don't attend to what Joel calls people's careers as suicidal people. And he also recognizes staying alive requires skills. And some of those skills that probably everybody in this room takes for granted. When somebody who's suicidal, I had somebody talk to me and they regard it as an absolute epiphany. They were just told, you can feel this way and not act on it. And just kind of being told, you can sit with your feelings, you can live through this, and you don't have to act on it, made a huge difference in this guy's life. He never attempted suicide again. To me, if you said that to me, I would say, well, yeah, duh. But there's all sorts of stuff that can help people over time, but you've got to know them over time. Now, this is a long slog. And my message to you guys and everyone I talk to is it's not a victory to keep somebody alive in a hospital and send them back to the life that made them suicidal in the first place with no new framework of skills, no new hope. And I really, really respect and honor you guys for doing this work. It's very, very hard. It's been hard for me to represent people who are actively suicidal, but it's been incredibly rewarding and I've learned so much from them. And I've tried to keep this short because I really believe more in dialogue than talking at people. So I'm really hoping there are questions. And thank you very much. I think you're supposed to go to the mic, so sorry.
You're also going to have to turn the mic on. So just have to, there's a button that you have to press up and you'll see it'll turn on.
Okay, is that on?
Yeah.
This was outstanding. I took several screenshots. I'm going to share it with my whole clinic when I get back. So thank you so much.
I can give you the entire.
That would be
slide.
so wonderful.
Happy to
Thank
do it.
you. Could you give an example of the documentation of the cons of the decisions that you're making? Because I never thought to do that. What a good idea. Do you have some examples of the language you might use to help
Oh
us with
yeah,
that?
I mean, so there's nobody who has no risk factors. Okay, so if you are discharging somebody who has even said word one about being suicidal, who's a white man, you'd better say, I get that there is a higher risk of white male suicide. At the same time, if you're discharging a young African-American woman or a young Latina, you can also document epidemiologically, there's just a lower risk factor that those people will kill themselves. Or you can say, you know, I tried to ask about lethal means and I'm not sure, like they were, I did my best to ask about lethal means, but I have some doubt about the lethal means thing. And what I'm doing because of this is I'm going to do a follow-up call. Or what I'm doing because of this is in Massachusetts, you guys may not know, but you can send VNA. You can send a VNA to visit somebody. I'm kind of iffy about recommending this because VNA people, they'll just pop you right back in the ED. But maybe getting the name of a friend who might come visit. So what you do is you say, here are the things that might give me pause. Here's what I did to address them. Because what you don't want is to be in the situation where somebody's asking you in court, did you know that white men have a much higher rate of completing suicide? Oh, you knew, like, and how did that affect you? Oh, do you usually document things that you believe are risk factors? Oh, and you didn't document this. So maybe you didn't even think about it, did you? Now, you know, it's unpleasant. You don't want to go through that. So what you do is you think about all the things that somebody might ask and you have an answer to them in the documentation. I could go on and on, but that's.
Susan, you and I have spoken quite a bit about the care process in emergency departments and what's common in emergency departments, and especially the balance, the decisional balance between keeping someone safe so that they don't try to hurt themselves or kill themselves in the setting versus their autonomy and their feeling of control and their feeling of a therapeutic environment. And those two things are often conflicting with one another. And I just was wondering if you might talk about if you have any insights on that decisional balance. And specifically, you and I was talked about access to your phone or your personal digital devices or your other belongings, being in street clothes, and whether or not that is how do clinicians think about these things, and are there legal parameters around the restriction of autonomy that we should be thinking about too?
Yeah, well, okay, that's another half hour, but I'll try and condense my response to that. First of all, a lot of this has to do with time and person power. So for a while, a long time, there were so-called sitters who, for some reason, a lot of hospitals said, well, we're going to assign sitters, but you can't talk to the person. You can't, I mean, so here's somebody who's feeling isolated, who's waiting 13 hours. There's somebody sitting there and they try and start a conversation. The person won't talk to them and they're suicidal. This is nuts. So if you're going to have people who are sitting, you should train them to be comforting, reassuring, listening, because a lot of attempts to harm yourself come from feelings of frustration. And another thing you might want to think about is nicotine patches, I mean, so even the most common things that people never think about, people want to smoke. People are sometimes being deprived of access to meds that they count on. That's something to bear in mind. As you know, I feel very strongly about involuntary clothing removal, and I did a lawsuit about involuntary clothing removal. So fine, the lawsuit ends up with the standard, you can ask, and if people say, okay, then okay. But if people say no, you cannot, like as happened to my client, totally peaceful person held down by 5 guys in the emergency department and stripped. So no, it's not worth it in terms of the clothing. You absolutely can and should search personal belongings. No problem with that. You should do it. Search purses. If people say no, you say, I'm really sorry. I got to search the purse anyway. I think not finding something in a purse or a backpack, that would be bad. I think that you can, if you're taking people's phones away from them, you should make sure that there is some readily available alternative. So if the person needs to make a phone call, one of the problems that a lot of people have is they're stuck on a bed in a like little cubicle. And God forbid they wander out of the cubicle. They got to pee, too bad. They want to make a phone call because like one of the things that matters to people tremendously is their pets. So if you just have a standard question, do you have a pet that needs to be taken care of? Can we help? Do you need a phone? You know, just think of people as human beings as opposed to potential suicide vectors. They have other lives, they have jobs, they have bills they've got to pay. So trying to anticipate the sources of frustration and anger, because one of the things that I do when I consult with hospitals is I look for what I call like iatrogenic escalation. And what I do is I ask the hospital EDs, I want to see the triage level people came in on. You come in on a triage level 3 and you end up in restraints an hour and a half later, the ED has done something wrong. What has the ED done wrong? If you come in calm and you're in restraints an hour and a half later, I want to know why. What happened to you? And maybe it's as simple as nobody came to talk to you at all. People have said to me, well, why should I talk to them? I have nothing to report. The labs aren't back. I said, you need to talk to people the most when you have nothing to report and say, I'm really sorry. We're still trying to do this. I'll get back to you. So I think you can, I'm kind of agnostic about the cell phone thing, except for the fact that valuables are lost and patients get really, really pissed off. Like my mother gave me this necklace and somehow it vanished. And people need their phones, like they need their phones. So you take away the phone, you'd better be in a position to give it back. That's one answer. I don't see anything wrong with having the phone. I don't know, they're glass, but I don't think people are going to hurt themselves. Joel Dvoskin was an expert for my case, my stripping case. And they were saying, oh, we had to take her clothes off. And Joel said, well, let me look at the room you kept her in. And like in 1 minute he'd said, well, she could hurt herself on this. She could hurt herself on this. She could hurt herself on this. Like your rooms are enough. People are not going to hurt themselves with their phones. Their phones are like really valuable to them. They might hurt themselves. That's why environmental, like, do an environmental audit. The VA has great, great resources on, you don't have to like make this up. You don't have to come up with this. The VA has done it for you on environmental audits. But that's like, I could do a whole hour on that. I think making sure people are comfortable, making sure they're warm, making sure the light isn't blaring in their eyes, making sure they know you care about them, making sure they've got food, giving them choices. Do you want Coke? Do you want Sprite? I mean, it's pathetic, but choices really help people. The warm, heavy blankets really help people. Love the warm, heavy blankets. Something to do, which is why Jasper's really great. If you're filling out Jasper, you're not going to be looking around to see if there are sharp corners. So I'm trying to keep these answers short, but that was a question that was
Thanks,
a big
Susan.
question.
We had a question through the Q&A around your comments about families scapegoating providers when they seek legal help after a loved one who is in treatment and dies by suicide. Sometimes families are appropriately looking for help in situations of real provider negligence and error. So maybe you can just speak to that issue of, the comment that you had mentioned about families sometimes, being desperate.
Yeah, well, so there is a situation that is common enough in case law. It's like the spouse who has had it with, it's usually a woman, has had it with a guy who's having all sorts of problems, and she gets him one way or another, either voluntarily or involuntarily, to go to the hospital. And when he's in the hospital, she comes and says, I'm leaving, I'm taking the kids. That comes up in cases often enough that I noticed the pattern. And I'm not like saying the spouse didn't have a heavy burden living with 2 kids and a suicidal husband. Yes. My answer to the scapegoating is no, they're not all scapegoating, and you can trust the lawyers to sift out the people. Like if they are really complaining about negligence, and there are cases of extraordinary negligence, like in Massachusetts, somebody's in a hospital, she's, the boyfriend goes to the desk and says she's been talking about killing herself, like with this stuff that she's carrying around in her purse. And the desk says, okay. And so, the next day she kills herself with the stuff that she was carrying around in her purse. That's negligence. And they found a lawyer. So I think that there is a lot of issues around, like when kids die by suicide. Oh my God, like if the marriage survives and the parents, if they're not blaming each other, the way the marriage stays together is lots of times they blame blameless providers. Although, like I knew one, he was a good friend of mine, he hadn't done anything wrong, but his ED, true story, the ED, the inpatient unit, the inpatient psych unit, and the hospital, like community services, were running on 3 different computers. I said to him, blank, it may not be your fault, but the hospital, like, how can this be? Because nobody was talking to anybody because they couldn't. And there's another example of like the system is thwarting good people who are trying to help.
We have one more. We have a question that we're going to read from online, but I wanted to get your opinion on issues where there's conflicting information about the person's suicide risk, either because different sources of information, like the collateral versus the patient, or because the patient has completed, an assessment like Jasper, and that information gets into the chart, and there's differences in the words, in the descriptions, maybe even in the level of the risk that seems to be conveyed by different sources. In that situation, any advice on how to handle it and on how to document it?
Yeah. You need to pursue those kinds of conflicts. Those conflicts are really important. Conflicts could be the family's making stuff up, or it could be the family's desperately trying to get through to an overburdened provider who doesn't want to listen and just wants to do the discharge. And those conflicts, I got to tell you, you don't have to worry about liability, but if I found one of those, I would jump on it if you didn't document. So, like, and this is another thing that really bothers me. You get into an ED because you are actually suicidal. People's feelings of suicidality are dynamic, they change, and nobody ever reassesses. And if somebody says, like, 8 hours later, well, really, I'm not, you don't necessarily take that 100% at face value, but it is a meaningful difference that you need to reassess. You can't just take it like the person came in, that's it. You need to be reassessing suicidality. And so if they come in and they say, now, like, I've changed my mind, that would be a good time to say, why? What's changed? What's happened? Why? And document that. But conflicts in the records, yeah, you got to document that you're aware of them and that you resolved them. You may resolve them wrongly. All that's required is that you be aware of them, be aware of the risk they pose, and make professional judgment. That's all.
Susan, can everybody hear me? Okay. We have another question from a Zoom participant anonymously asking, I guess this can kind of open it up to the whole room, any psychologists in the room. But just, you talked about the importance of, giving people the skills that they need when they're getting help for seeking treatment for suicidal thoughts, and what kind of skills could be taught that would help them. And then are there any programs out there that, would be relevant?
Well, I can answer that, but I'll also like let the room answer that. So there's all of these different alphabet soups that turn out to be very helpful for some people. So the thing to remember is nothing is very helpful for everyone, and don't give up. CBT helps some people, and they have a special CBT for people with suicidal ideation. DBT helps some people, and some people hate it, but it really helps some people. CAMS, I think, is great. And one of the things I want to raise for researchers and clinicians that I think is really, really important and valuable to take on board is that the CAMS studies, the studies about these modules that work, what they find is suicide attempts down, personal distress down, suicidal ideation not down. And the framework I would like to propose to you is it's okay. You don't have to stamp it out. What you have to do is teach people the skills to live with those kinds of feelings. And it's fine to have a model treatment that doesn't reduce suicidal ideation. If it reduces suicidal attempts, then it reduces, really importantly, personal distress, because people are desperate, they're frantic. You need to, like, if you see somebody who hasn't slept and they're frantic, that's not a good sign. The insomnia and the kind of agitation. But people can live for decades. My former client, for 7.5 years, every week, she would call me. Sometimes she would say things that, this does make me smile. She would say, like, I have ordered online seeds for a plant that when it's grown is poisonous. And I was like, you go, girl, like, fine, keep people alive as they make it through. And she died, sadly, she died in a nursing home of COVID. And the whole nursing home situation with COVID, you do not want me to get started on, because there is not enough litigation in the world.
Thanks, Susan. I just wanted to also give my quick answer to the question that was online. I think you should go to the CAPES website. because the CAPES website has, for people who are struggling with suicide, has a bunch of really great websites that are linked there that can address that issue of learning skills to live with suicidal thoughts. And what Susan mentioned, many of the core professional strategies like safety plan intervention, like collaborative assessment and management of suicide, which is CAMS, cognitive behavioral therapy for suicide, really focus on two things. Focus on helping the person to manage, not eliminate the suicidal thoughts and desires, but also to identify and address the drivers, the things that are causing the person to want to kill themselves. So those are the professional services. But then there are also self-help resources and other groups that Laura had mentioned that are linked on the site that also focus on some of these same issues.
And thank you. Or, oh, you.
This is a
I can
comment,
answer
not a
question.
question.
Okay.
Sorry. We have a comment from Linda DeMeff in the chat from Jasper Health saying Jasper contains DBT and CBT skills taught by people with lived experience designed specifically for people in acute suicide crisis. So just building on what you all are saying. And I just have a positive comment. So DeQuincy Mefrelazine, who you've quoted here, he's a member of our advisory board. He's a consultant through EDC and Zero Suicide Institute. So I sent him an email with a kudos saying he's quoted in your presentation. But I just wanted to say thank you. Thank you for bringing his voice to the table.
Thank you guys for the work that you're doing. And yeah, Jasper, I actually should have disclosed years and years and years ago when Jasper was a twinkle in the eye of the people who developed it. They hired me as, you know, kind of a legal consultant. And I said to them, first of all, most of your legal questions are not going to be answered by me because they're about things like the FDA. Second of all, make sure that whatever the cover is of Jasper isn't breakable. I mean, that's about what I did for them. But it's great. I'm a believer. They haven't paid me in years. So I'm able to say this completely uncompensated. I think Jasper's a really, really good idea for a whole variety of reasons.